Today's topic of choice is bradycardia. The scenario is as follows. Mr. Shen Lin is an 82-year-old male with a history of hypertension, and he was admitted via ambulance after an episode of fainting whilst walking in his garden. This was seen by his wife, who called the emergency services. Paramedics at the scene noted Mr. Shen was bradycardic, and once questioned about his medication list, he recalled having an overdose of bisoprolol tablets, 3 tablets. Aside from the most apparent cause of this man's bradycardia, other important differentials include an inferior MI. In inferior MI, the inferior myocardial wall and the sinoatrial and atrioventricular nodes are affected, as they are supplied by the right coronary artery, which is blocked in inferior MI. This can cause bradycardia. Electrolyte abnormalities include hyper or hypokalemia, hyper or hypercalcemia. Hypothyroidism classically results in bradycardia, as does hypothermia and infection. Moving on to ABCDs of assessment. So we begin with the airway. This must be given special attention to in a bradycardic patient, as they may have reduced consciousness, which may result in soft tissues occluding the airway. Breathing. We check the respiratory rate saturations and perform a full respiratory examination. Exclude pneumothorax, pneumonia, checking air entry. C. For circulation, we assessed hemodynamic stability via the measurement of pulse, blood pressure, CRT, and urine output. A full cardiovascular exam should be performed, looking out for heart failure due to bradycardia, since the heart rate no longer supports the needs of the body. Secure IV access and perform an ECG. D. For disability, we check the GCS and blood sugar. We expose the patient with dignity. Any other physical examination that is warranted can be carried out at this stage, not forgetting to check the temperature. Initial investigations include ECG to rule out inferior MI. This is very important. Bloods. From here we can identify if any electrolyte abnormalities are causing the bradycardia, as well as hypothyroidism. And the chest X-ray can show any consolidation or pleural effusion. So here we have an ECG showing sinus bradycardia with a rate of 35 beats per minute, with everything else looking quite normal. Initial management, as always, is to support the airway, providing oxygen if required. We use atropine 500 mg IV to increase the ventricular rate to overcome bradycardia. Delivery of atropine can be repeated every 3 to 5 minutes, if not successful, up to a maximum dose of 3 mg. If this does fail, senior help is required. So at this point you would consult the consultant or the registrar. Thromboprophylaxis should also be prescribed when needed. Definitive management would be to correct the underlying cause. In Mr. Shen, it was the overdose of bisoprolol. Perhaps offer him a Dorset box. We would transfer the patient to a stable, when stable, to a cardiac monitored bed, just to keep an eye on them. And that is the management of bradycardia. If you do have any questions, please leave them in the comment section below. Thanks again for watching. Any improvements as well, please do leave them in the comment section below. Thanks again.